NiceSpeech Lady. Useful resources for medical SLPs. Created by one who is just like you out in the field. Creative, practical, evidence-based resources. Building up, learning from one another.
Hi, welcome back to NiceSpeech Lady. My name is Wilson Nice. I'm a speech pathologist and owner of NiceSpeech Lady. We have a resource website for speech pathologists and students, as well as a private practice clinic here in Socorro, New Mexico. And we're glad you're here. I've got a great show today. I have another wonderful talk planned with Walt Fritz, who has an introduction to manual therapy, voice and swallowing disorders. So we'll talk a little bit later down the way. First, I want to just share my screen and let you just see some of the things we have going on at NiceSpeech Lady. So here, if you go to the main page of NiceSpeech Lady, just nicespeechlady.com. If you go here to the left side, you'll find our resource summary list. These are all of the different folders of data that I have of complementary resources, assessment tools, treatment ideas, patient rating outcome measures, lots of different things here. So please check out all of our resources. They're also organized here under Library 1, Library number 2. And then I also have information of some measures that we've created to support testing, as well as blog posts and other things. So please check out nicespeechlady.com. We would appreciate you to reach out to us if you have any questions. Now we'll move to this part of the show where I'll talk to Walt Fritz. Well, I know it's been a while since we spoke. It was last year sometime, I believe, when we had our last talk on camera. And I know you are coming to New Mexico soon, so I'm excited to see you.
Yeah.
So I can't wait. I know that when we first met, I was like, can you come to New Mexico? Come to New Mexico. And I was so happy to take the introductory class. So, so for those that, don't know what manual therapy is or, how to incorporate it into their practice, what is your, in a nutshell, description of it?
Wilson, nothing comes out of my mouth in a nutshell. It's all like long and drawn out. Anyway, manual therapy is, it's a lot of different things to a lot of different people. To me, I love, there's a quote that I like it so much at the top of my Facebook page. Essentially, to paraphrase, it's time to stop viewing manual therapy as something magic we're doing here in the tissue, but instead to see it as simply another form of communication with our patient's brain. And there's so much evidence for touch, for massage, for manual therapy, for laryngeal manipulation, for these things moving beyond the concept of the issue in the tissue, which is how it's always sort of phrased historically, and unfortunately, even in the research today. And to see it as a very nuanced, multifactorial way to find another inroad with patients. And I love how speech pathologists sort of combine this in with their work. And some of them are like, yeah, I'm going to do manual therapy with all my patients. And some are saying, you know what, if they're not responding to the interventions that the evidence says should work, how about if we add touch? It's about using it in a novel way and not seeing it as a clinician expert-based model of needing to know exactly how to palpate and how to remediate the issue. And I think that, in a nutshell, if that's such a thing for me, that kind of sums it up. The way I practice here in upstate New York, as well as how I teach to others, I kind of almost think about it as a 50-50 mix between, what we do with our hands, and the other 50% is what we do with the clinical interaction, with the therapeutic relationship. I believe in shared decision-making as a core component, not just of manual therapy, but of everything I do with patients. And it's kind of the drum that I beat on shared decision-making, because I think it's odd, interesting, understandable, lots of different words to describe it, how when some stranger comes into our office, we're expected to know how best to work with that person, how best to treat them, how best to interpret the evidence, as if we take that evidence, we look at the patient and say, okay, you're a perfect candidate, and then we apply the intervention. Well, that's kind of what we do in medicine and healthcare, et cetera. But the core piece of it is missing, and that's the third wheel of the evidence-based model: patient preferences and values. And that's really what I embrace in the approach that I use for both treatment as well as education.
Well, sure. And with the patients that I see here in my clinic here in New Mexico, I own a small private practice here in Socorro, New Mexico. I use that same concept with all of my patients. And really, a lot of families at first don't even quite know what to do with that. Some
Hmm.
patients are really kind of dumbfounded that it's something that they were expecting to come in and I have this is what we'll do. We'll fix this. We'll, da 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 da. And we've actually started instituting, especially with patients that have high needs, a pre-evaluation consult, then the day of the evaluation, and then a post-evaluation consult, especially with children or adolescents that have special or high needs that are different, that would require additional supports. And it's in that phase one that I meet with the family, and we go through the paperwork, and then at phase two is the day of, the evaluation day, and then phase three is okay. I looked at all the information. I've kind of gone through the data. I've thought about it. I've heard what you want. This is where I'm thinking. Let's negotiate this out. Let's talk about where we want this plan of care to go. And it's worked well with our high needs patients here. And that's something that I don't think I would have been doing if I hadn't have taken your course. And I know we've talked about this before, but I don't think I've ever taken a CEU course that really talks as deeply into patient preferences and patients' values as the courses that I've taken with you, and I've appreciated it.
Yeah, thank you. And you use the word negotiation because that's a core component of what we're doing here. And shared decision making to me, well, in a perfect world, we're equal 50-50 share in terms of decisions on, treatment, et cetera. But it never works out that way. I mean, 50-50 is optimistic and seldom attainable. Honestly, sometimes my patients, they lead. They really do lead by telling me, no, you're not quite there. Move your hand here or press harder, which irritates some people because they think the patient is sort of controlling the session. And to me, it's like, yeah, they're controlling their own destiny. And to me, that is a huge win. Other times, I need to take power back because maybe they're unwilling, incapable, or just don't quite understand the core concepts of why their input could be useful. But to me, it's even when we're here with a big power disparity, I'm still trying to sort of level it off as much as possible. I do also understand, and it really hit me hard. I was teaching in Asia last fall, and I was aware of this, that culturally, socially, economically, patients respond differently to requests to be that active participant in a therapeutic model. But it doesn't always work that way based on those social and cultural norms. And it really struck me hard in an Asian culture where not all, I don't want to stereotype too much, but that's not the norm at all. It's not only unexpected, but it's also not accepted really well. That deference to the expert is almost the norm, the expectation. And it really took me a while to sort of wrap myself around there and say, okay, I get that. How can I incentivize your participation as my patient to let you see that what you feel, what you fear, what you hope for, all can have value? And that was an eye opener for me. I've taught in other countries before where social norms are certainly different, but it wasn't until a student in one of those classes brought it up to me that really made me look hard at it. And I'm guessing we all face those people that, no, I'm not used to this in a medical setting, in a healthcare setting. And I simply don't want to do that. I respect that. If a person doesn't want to participate and wants me to make the calls for them, I'll do it. But I'll do it grudgingly, and I'll do it a little resentfully and a little with a pouty face because I want you to see that you have value. And if we can do that, great. If not, we'll still do the intervention. It may not be quite as focused kind of focused directly on your needs because you're asking me to make those calls. But either way, shared decision making has become really that centerpiece of not just what I teach, but how I treat patients as well. I love that concept of bringing them in for sort of a pre-visit to sort of warn them in a way. I do that through my website, through materials that I distribute. But a lot of times, they're kind of sitting across my desk from me, a little doe-eyed, going, "What do you mean? I don't understand this," or when we get started. But with a little bit of practice, that shared decision making piece can come out really strongly.
Well, when I took your introductory class, it was mostly a manual table approach. And I know that you've
Yeah.
shifted to a chair model more in the speech therapy realm. And I have found that just that shift does create more of an active role in the patient in terms of feedback and in terms of, giving responses. So that's one thing that I've seen that has helped that just kind of organically. But what are the ways that you have worked to prepare patients for, other than the obvious, other than just verbally describing it like you did in the class? Are there other ways that you found that can help patients understand the dance?
Yeah. So, granted, my typical clinical encounter is different from you, a speech pathologist clinical encounter, but there are aspects of it that sort of cross boundaries there. I have on my private practice website, I have a video right up at the top that it essentially shows me doing certain things with people. Not necessarily specific to the speech pathology type diagnosis, although I think I have a little bit of that included. But to show people, here's how I work. They're seeing me interact with, like you said, a massage table. That's the bulk of my physical therapy type interventions: low back pain, neck pain, that sort of thing. But I think for the clinician, allowing your website to sort of be that tool, your Facebook page, or however you're marketing that, to let patients see you in action, whether it's still photos or videos, accompanied possibly by you talking about your work, talking about, you might expect this when you see a physical therapist or a speech pathologist, but we're capable of so much more. I think that pre-training is really helpful. And I say this at almost all my classes. And I think it's pretty true. When somebody comes to see a physical therapist, they kind of have a thought bubble in their mind of what that's going to look like, right? There's going to be exercise equipment, guy's going to be dressed like this, all those sorts of things. They come into my office, I don't have all that exercise equipment. I got a chair, I got a table, I got me. So I think pre-training, pre-warning them is necessary. But also for you, let that patient see what a speech pathologist is capable of, because for the most part, they have no clue what a speech pathologist does for a living if they're seeing you for the first time. So give them an opportunity to get to know you before they even walk in your room, whether it's the website, whether it's an email introduction, those sorts of things. You're selling yourself not as Wilson, but here's Wilson with, I'm not terribly fond of the tool belt analogy, but we have a lot of different methods at our disposal to help you get through this problem. And manual therapy, to me, slots right in with one of them. I also say that at every one of my classes. I never, ever intend manual therapy to be used as a standalone. It should be incorporated, embedded in that tapestry of all the different things that we can do with another person to help them get through whatever issue they're dealing with.
And one of those avenues for treatment that you blend in with the manual therapy, I know you've talked recently about, folding in exercise and movement in the context of all of that, and you shared some things before we started recording. So there was some talk a little bit about exercise when I took your courses, but I'd like to know kind of what's new and what the research is showing, and where are things going in terms of exercise, in addition to the manual therapy approaches for speech therapists.
Okay, Wilson, I left a gap there. I need to go get a Kleenex. My nose is running.
No problem.
They didn't want to rudely keep wiping my nose with my hand, so
I could text you a Kleenex from New Mexico.
That's okay. That's okay. Okay.
So on the topic of exercise and movement and strengthening, in with what you're teaching speech therapists, in our field, non-speech exercises as it relates to articulation isn't showing in the research to be supported for outcomes, but I could certainly see how it would assist, in swallowing goals, in bringing in exercises orally. And of course, we've worked on we've talked about throat exercises in the past, but folding those in together, what are you finding that people are using, or what is the research saying about exercises in relation to your work?
I don't know whether there's any, well, there's certainly no research right now that correlates my work with the findings that they have. Let's just put it straight. I say we, a speech pathologist in California, and I are just starting a study now on what we call laryngeal anchoring to see if that can be an effective means of strengthening a weak swallow or whatever that is. So hopefully we've got some of that rolling out in the next year or two. But I think it requires us to look deeply at the word exercise and strengthening, right? Because I think we tend to oversimplify things. We tend to oversimplify things for our patients so we don't lose them. But in the process, I also think we tend to oversimplify things up here in our own heads. What is an exercise trying to accomplish? A lot of times we say, well, they've got weakness, we need to make them stronger. I mean, that's a simple, cause and effect type of issue. But what goes into the exercise that creates strength or improve function, I think that's really where things get nuanced. Classic muscle strengthening, the physiology of muscle strengthening, is one that requires true fatigue. You have to work a muscle, the person and their body. You have to work the person to fatigue with sufficient either resistance or repetitions so the muscle begins to fail, right? Where they can't do anymore, they get close to that. You let the person recover a day or two, whatever that might be, and then you repeat it, adding resistance or adding repetitions over time. That's classic muscle physiology for strengthening. We can envision that with, weightlifting, right? You take the body to fatigue, let it recover, and over time, you'll be able to hoist more pounds up in the air. But I don't know that that's really the exact mechanism that we're looking at with some of the disorders that you all work with. And we've been doing it, the exercise, inclusion of exercise, especially with some of the tongue work that I've been teaching over the last couple of years, taking a look at those stretches, the manual therapy interventions, and sort of coupling it with resistance. The tongue is by far the easiest one to demonstrate, and the one we've really ventured deeply in. The concept of improving volitional ability, motor control, if you will. We do some things where we'll sort of trap the tongue in the floor of the mouth and then ask the patient to lift the tongue against resistance. I learned the hard way, don't give maximum resistance because they fatigue really quickly and they get sore real fast. So instead, applying a very graded touch so that the patient can begin to sense some motor control, some motor output. I'm giving the input sensory-wise, right? Whether it's resistance, whether it's maximum, minimal, or somewhere in between, and allowing them to motor plan, okay, what do I need to do to work against that resistance? We'll do things like we'll trap the tongue up into I'll put my thumb up in the roof of the mouth and the patient comes and they capture my thumb. And as they capture it, what I do is then I'll say, okay, go ahead and suction to the roof of your mouth. And I'll say, now hold it there. And then I begin to resist. What I'm looking for is essentially along the whole length of my thumb, what part of their tongue is really participating and what part isn't. And very frequently, it's the back of the tongue. So what I'll do is just a little bit of an input, a little bit of sensory input, whether it's tapping the tongue or going up and tapping the roof of the mouth where I like that tongue to reach. And what is so interesting to me is that simple little sensory input. In most cases, unless there's some major issues going on, post-surgical, post-radiation, et cetera, or stroke, where they can immediately respond, and you get this instantaneous response. Not just an instantaneous response for responding to my tap, but then when I go ahead and I do the whole tongue again, there's a much more even distribution of resistance to my thumb. I was just teaching a class last weekend in Nashville, and we were going through some of these things in terms of, tap the back, tap the middle, tap the front. And someone came up with the observation that, these sorts of exercises, getting the person to have better, like selective control of parts of the tongue, and not just back to front, but even side to side, really might foster the normal peristalsis that the tongue does when swallowing occurs. And I love this piece of the work that I teach. Is I'm not a speech pathologist. I don't pretend to be one. I introduce a concept and then let you all run with it. And I love the feedback. Just like you told me, I had not heard that from you, Wilson, about that sort of that pre-visit before the evaluation. But the way speech pathologists and others blend, interpret, and modify my work, to me, that's a big win. So that strengthening piece is it's taken a long time for me to really realize that the two can really blend well together, even though they seem like they're completely walled off. Stretching and strengthening, those are two problems they're addressing in two different interventions, but maybe they're not as disparate as we once saw.
Well, what you were saying about, triggering the peristalsis, when we open our mouth, when we lick our lips, when we're starting to put something in our mouth, all the chambers are getting ready. Even our esophagus is getting ready.
Mm-hmm.
The lips, the tongue is sending signal to the brain. Okay, get ready mouth, get ready throat, get ready esophagus. Everyone do their job. And the chambers, it's a chamber reaction. Boom, 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 boom. And I'm looking forward to getting to see these new techniques, that you're doing in an introductory class again, because I'd like to sharpen those tools because, I've used the manual therapy techniques, seems like more than any type of patient. I've had a lot of patients come that have had esophageal involvement. And I've just noticed a trend of patients not wanting to change their food plan or not wanting to take medication. And if they don't do one of those, usually then they need some additional support to help with their symptoms of reflux. And so that's been kind of one topic that I seem to get a lot of patients like that, where
Yeah.
they don't want to, they either, they want their cup of coffee, or, they want their green chili here in New Mexico, and
Mm-hmm.
they're taking medication, but it's not taking care of all the symptoms, or they change their diet. They're still having symptoms, but they don't want to take a medication. And so they come to me to work on the esophageal piece. And I'm just wondering if that's something that you've seen in some of your classes.
In terms of,
Of
say it again.
a speech therapist reporting
Okay.
that they're getting a lot of patients with, maybe your advanced classes when you're circling back around to therapists that have taken your course, that patients are, they're seeking out manual therapy because they either don't want to modify their food plan, or they don't want to take medications that would have side effects that wouldn't be ideal for them.
But that one I've not really heard as feedback in terms of the patients being maybe aware enough from social media or wherever that manual therapy is an option. I would love to hear that, but I've not heard that as a report from clinicians, whether it's coming back for the advanced class or on the Facebook group, et cetera, et cetera. But that would be kind of neat, huh? Do you do Walt stuff? People will be calling you soon. No, just kidding. It's certainly a possibility, whether or not they're coming specifically for this, but saying, okay, the typical intervention for speech pathologists with your disorder is defined by A, B, and C. But there's other things that we can mix into that. We have that issue with, do we have full support from the evidence for all of this? I guess it depends on how deeply or how we interpret that with a rigid or more flexible lens in terms of the evidence. There's certainly, it's one of the things that I've learned since I started teaching speech pathologists is I gotta up my game when it comes to providing you, the clinician, evidence to support this work. Not just, does this help swallowing, but understanding that the basic framework from a behavioral aspect of touch, of manual therapy, of empathetic, appropriately applied touch, it can offer a lot more than just what we think, like I said earlier, what we think we're doing to the tissues. Another thing we've been doing more recently, and it happened really quite by accident. A lot of times when I teach my advanced class, in the beginning, the introductory class, sometimes the class sizes are such where there's simply no time for you, the student, to demonstrate the tongue techniques on me. We do demo where I let you feel it from me and let your partner respond back. But the time, et cetera, isn't sufficient. But in the advanced class, it's set up differently, especially for the tongue work. During that, every therapist treats me, lets me feel their touch, their stretch, et cetera. And I think one of the more universal things that people are doing wrong is when they're holding their tongue. Not that we're clamping down hard, but they're simply not grasping it with sufficient force to really make an impact when you stretch. So we started doing something where, okay, I'm going to ask you to take hold of my tongue, and then I'm going to gently try and pull back against you. If you lose my tongue, you're not squeezing hard enough. And that was a really good way to get clinicians to understand, okay, maybe I need to be using just a little bit more force. But in the meantime, adding that resistance sort of opened up a whole nother door to resistive exercise. I mean, you're familiar with the Masako, obviously, where you're distally anchoring the tongue and doing a swallow. We're it's think of it kind of like that, where we're anchoring the tongue with variable levels of resistance instead of a complete block. Maybe somebody can't respond at all to a complete resistance, where they can't win, so we grade it. And yes, we're maybe gaining strength over time by providing resistance, but I think it's more about building awareness centers in the brain for novel outcomes. And I think that's truly what's at play versus the building muscle perspective. And it's sort of the avenue that we're taking for a lot of the exercise, not just with the tongue, but instead of doing jaw work like I was taught, we go in there with your finger in the pterygoid region and I release the tissue. Okay, we might spend time doing that, but now we're doing a lot more. Okay, you came in to see me because of problem A with my finger in this space. I'd like you to go ahead and do that. Open, close, clench, go wide, go side to side, maybe even give them something to chew on while I've got my finger in that space. Not only does it provide exercise, but I think it also broadens the ability for them to recognize whatever he's doing right now, that's relatable to me. All right. And I think that's the key piece here. We're communicating with the human being and not just the tissue in distress.
I do not recall us doing any chewing with the jaw release before. I know that that's a new one, and I do remember it just being like just an open, wide, and just frozen chicken, moving around and getting in there. But I think that that is well, definitely would have to be done in a chair, which I know that that's now how you're doing the classes, teaching that. So that is great. And so what is something that people don't know about the work that surprises people?
The differences in approaches. I think that's one thing. There's sometimes people have done some training, whether it's formal continuing education, something at university, around the job training, when it comes to, myofascial release, what I used to call my work. And a lot of envision it as very aggressive, deep work, or the concept of laryngeal manipulation, which probably hits a wider range of speech pathologists, whether it's very few people have formal training because there's very few people doing that sort of work, but they've observed it where you basically grab hold of the thyroid cartilage and you sort of wrangle it from side to side. The evidence shows that that's effective for boys, for muscle tension dysphagia, for some other things, et cetera. But what the evidence doesn't define is that the manipulation, the movements have to be forceful. Also, the evidence doesn't stipulate that the patient should participate. I believe in participation at all levels. In laryngeal manipulation, for instance, those early steps, basically the patient is sitting there, laying there, wherever you're doing it, compliant to your touch. They're allowing you to beat the crap out of them, as I like to say, because I don't like aggressive manipulation anywhere in my body. But they're allowing us to do what the evidence said. We say the evidence shows that we do this, we lower their larynx, and then we start them actively voicing. It's like, okay, the active part only comes near the end once we've done what we think is necessary. And all I'm proposing is, can we introduce it immediately? I now teach laryngeal manipulation in the introductory class, Wilson, that I didn't do last time, because it's a result of my own master's program that I just completed with a survey from speech pathologists who learned my work, and they learned laryngeal manipulation and said, you know what? Both of those had value. And instead of seeing my method as different or superior, it's like, let's recognize that. Let's recognize that laryngeal manipulation has value, that sometimes deeper, more aggressive soft tissue work can feel really valuable to the N of one who's sitting in front of us. I don't like it, so I don't apply it typically, but now I do because you might. And I think that's one of the biggest differences, is seeing this wide range of pressure and styles that can be incorporated in manual therapy. And I also think the biggest surprise to people, even though I try and pre-warn people, is this shared decision-making model. And maybe because I've been doing manual therapy like this for decades, I find that easy. I find the shared decision making, the empowerment of each individual. That's the challenging part of the work that I teach and the work that I do. And I think that's probably what leaves the biggest imprint on speech pathologists who've taken the class. Sure, we're using manual therapy, and those are cool techniques and they often help. But the inclusion of shared decision making can benefit not just manual therapy that you do, but like you said earlier, literally everything you do. And to me, that's the take home.
Absolutely. I have we were talking a little bit earlier about how I do a pre-evaluation consult with my high needs patients here at the clinic. And then we have our phase 2, which is testing, and phase 3, which is talking about the results and negotiating a plan. And I recommend things, and then we modify them based on the conversation. And I think that we started out only doing the phase 1, phase 2, phase 3s with children, so that I could be best prepared for the day of testing, especially if someone has had a history of trauma or if there's a language difference. That way I can just be prepared, for the testing. But I've also found that there's a benefit to it with the adults as well. And I think that, just kind of really taking time to ask them what they're wanting is great. And what you were talking about in regards to why not bring in the function in the beginning rather than the clinician just manipulating it, and then later you work on the voicing or the swallow or whatever. I think that's like, if you can bring it in the beginning, that's the best way of showing the patient, I'm going to work myself out of a job with you. My goal is for you to not need me, so that I can show you how you can do this to yourself, and you can start, tomorrow, replicate what we did in the visit to eventually, achieve the goals and fade myself out. And I think if with the other model, though, if it's, all clinician and then, all directed by the clinician, I think then that's not giving the patient the route to, there's an exit plan here that you're not going to be a patient here and I'm going to fix it every week kind of model.
Yeah. Well, you might remember this from the class too, that I started making this promise decades ago now to patients that within 3 sessions, if something we're doing is not creating a lasting positive change, one that you define, not me, then do something else. And I think that, well, first of all, it might put pressure on the newbie to this work. It's like, oh, I don't know if I can achieve those goals. But to me, it allows the patient to see, okay, this might take a while. It might take longer than 3 sessions. Obviously, sometimes it does. But I'm not in this for the long haul, especially if they're, whether it's copay, whether it's private pay, whether it's they're driving an hour to see us, right? It's like, okay, how long until I start to see the benefit from this? And I think that's really helpful. I'm curious, though, Wilson, about your model, that sort of 3-phase model, the first session being more of a conversation on what might happen. And maybe if you do what I said we should do, we should sort of pre-train people via our website and everything. But I get so many patients who come in on that first session. And one of the first things they often ask is, are we going to actually be able to do some work today? I hope we will. Because, I look at myself as sort of a unicorn in physical therapist. I don't necessarily say, okay, our first session is devoted 100% to evaluation. We're going to take all sorts of measurements and tabulate them and talk about them and set goals. And maybe because I'm self-employed and my supervisor lets me get away with anything, but my evaluation session certainly collects that data. But while we're doing evaluation, I will often roll in some treatment, not just to give them a sample of it, but just to see their response. I'm curious if you've hit any sort of a backlash from not providing intervention to what it sounds like possibly even the 3rd session.
Well, phase 1 is an unbillable visit. We don't charge for that. It's a 30-minute complimentary encounter that we can't bill for. I also, on the virtual side, if that's the case, the stage 1, no matter what, is not billable. But, and then stage 2 is, testing day. Sometimes with adults, I do stage 1, and then at stage 2, I combine stage 2 and stage 3, where after the testing, I've already heard from them what they're wanting. I touch base at the end. Okay, do you have any questions? Tell me anything I didn't cover, and we start negotiating. And so we do 2 and 3 together, a lot of times with adults at the same visit. And I I give a lot of time for evaluations. I give 2-hour slots, and I know that's kind of luxurious, but I like to, it's investing. It's investing in the plan of care. It's investing in the patient. And I tell the patients, you won't ever be here at the clinic this long ever again for this amount of time. After this, it'll be, an hour follow-up visits or 45, whatever the patient can tolerate. So for adults, if we're collapsing 2 and 3 together, they'll have the list of recommendations that we've negotiated together. But at any stage of the game, I want to offer something of value to every patient. Mm-hmm. After every visit I have, even if it's the pre-evaluation, consult, it's like, I would like you to fill out this additional form and bring it back next time. I would like you to think about this or this or this. And because, this is where I'm going to be interested in seeing. And if you have other questions, get back to me before stage 2. So at the end of every encounter, I have an HEP recommendation, try this before next time. And it may be for pediatrics, it may be asking the parent to model certain sounds or certain language until we have a chance to come around to phase 3. And then we'll go over the results because usually I can find 1 or 2 things of value to be able to say, I need to score the test. I need to look at the data. However, until you come back for stage 3, this is what I recommend. So I don't bill for treatment on stage 2s. Usually I just bill the speech code for the evaluation. But now we do have a code that does for the stage 3s. We can use a caregiver education code. And I usually just use that code instead of a treatment code, because normally if we're doing a phase 3 by itself, it's a parent or a caregiver, not the patient themselves in that phase 3.
Great.
So, I always like to leave with something. Okay, before you come back, think about, even if it's just think about this, or could you consider this idea? I always give them something of value, because if they've come into the clinic or we're on the computer, we're having a visit in some kind of capacity, I want them to leave that appointment saying, I got something of value. I have something that I'm taking away from this time, even if it's just to ponder something or make a list of words that are the words that they have difficulty with, or start tracking these trends in your swallowing, or start, tracking how your speech changes at the end of the day and rate. And, I like to make a lot of rating forms and track trends. So normally they go away with something of value.
That's great. Yeah. Great to hear.
Yeah. Well, anything else you wanted to share about manual therapy?
Oh my gosh, I could go on forever, but let's do this again. We can break this up into concepts and sections if you want to chat again about this, because I can go on, and I do go on and on, talk to people who've taken the class, they know that. But no, I just anybody who has questions or comments for me, please feel free to reach out, whether it's through an email from my website, waltfritz.com, or social media. I love sharing this work. I love teaching this work, but I also love that feedback on how people have uniquely interpreted my work. And I just think that's the blessing of the work that we get to do with people, not only help others directly, but that indirect piece, I think, is just so rewarding to me, that, you can give somebody an idea and then they take it and make it their own and help other people. That's really, what makes me do what I do for a living. So.
Well, it's very meaningful to me, and I appreciate it. It's very relevant.
Yep.
It's familiar.
Yep.
It's all those things.
Is it relatable? I've got a lot of new words, Wilson. You're sort of throwing out the words there, and suddenly coming up with new ones, or people are giving me new ones. And one quick aside, I was teaching again the class at one of the Hong Kong classes I was teaching in October, November. And I have a very, I call it an iterative style of dialogue with my patient. What do you feel? Is that familiar? Those sorts of things that I always thought was a fairly non-threatening engagement. But a therapist at one of the Hong Kong classes said to me, you're interrogating people. And it's like, me interrogating? No, I'm not interrogating. But once I sort of got off my defensive high horse, I realized that there are aspects of interrogation that this shared decision-making model that I teach and use has. but I want to envision myself as the good cop, not the bad cop doing the interrogation, right? I don't want to feel like you're being, sort of threatened and browbeaten to give me information. I want you to understand that the information that I'm asking for will benefit you if you're willing to help me help you. So I'm trying to keep that new concept in mind of interrogation, not to totally deny it, but to keep it on the softer side of things.
I wonder if there's a way that how comfortable they feel about giving feedback could be measured. From
Yeah, yeah.
like kind of like there's a pain scale where you have one slash here, and this is no pain, this is all the pain, and they just put a slash and then we do the equivalent of the number. But if I'm going to be doing this manual therapy with you, how comfortable would you feel telling me what you're experiencing? How
Yeah.
how comfortable do you feel? And they could make a mark, oh, you're only a 3. Okay.
Yeah.
And then you could negotiate. Well, instead of doing it verbally, we could do it non-verbally for starters. How comfortable would you be with a thumbs up, thumbs down? And then they may be an 8, and then like you move into that. I'm sure that I'm sure that there are mechanisms to make it easier so that we wouldn't make people feel like they're feeling interrogated, where
Absolutely.
they're giving consent
Absolutely.
in advance.
Yeah. Yeah. That's a really good idea. Another quick story. I'm full of quick stories that don't end up being quick. Had a patient last year who came into me for some jaw issues. She had seen a lot of therapists, number of which function in a more, I don't even know how to say this, in a way that there's no word spoken. The therapist is doing their thing, allowing the patient to sort of drill deeply into their own past and present to sort of reflect and relate to what's happening. And it's a model that I recognize from a lot of my early training where, you want that patient to get in touch with emotions and things like that. And, sometimes we're sort of, guiding them a little bit too much into emotional responses and memory. But this person had told me their history. So, okay, we went to work doing some of the TMJ work that I teach in the classes and, asking, what do you feel? Is that familiar? Does this feel like it's part of that issue? Would you like more pressure, et cetera? Bring your hand up and help me help you, those sorts of things, which, they're pretty much the norm of my practice. We finished the session and I asked the patient how they felt. And she said, it feels really good. So she wanted to come back again. And she did. She came back a week or two later. And I said, so give me feedback from that last session. She said, I really like what you did. I really do feel a difference. She said, but I really did not like your questions. I didn't like you interrupting me. I didn't like needing so much feedback from you. I'd prefer just to let you do your work and let me process it silently. I said, okay, we can do that. I said with a little bit of a pouty face because I don't like doing it that way. But okay, patient, they're allowed their choices. So we spent that session in silence. I kind of remembered where we were working, the things we touched on. And I did what, as an expert, I was tasked to do. And we finished the session. I said, so tell me about that. And the patient said, well, you never really hit the spot. And I wanted to say, see, I told you so, but I didn't, right? I said, maybe we can come to an agreement, right? Somewhere in the middle between interrogation and total silence. Maybe there's a sweet spot. And maybe that's kind of what you're discussing too, the sweet spot for you that I'm not quite sure whether on an intake, they would know what I'm really asking for. There might be something, whether we really need to scale it objectively or just keep in mind, how much are you willing, not willing, because I guess that's the wrong word. How much do you see the value of participating, right? And on the third session, we did that. We found a balance point where I didn't interrogate her, but I didn't let her just drift off completely. Finding a neutral, or negotiating, as you said. Mm-hmm. So there's a blueprint for this, but the blueprint is a fuzzy one. We're making things up as we go along based on our own perceptions and beliefs, as well as the patient's own perceptions, beliefs, values, and expectations.
Can I circle back around to something that you said when the first session? She said this patient felt good. It felt good, and then coming back at the next one, I felt like you interrupted me.
Yeah,
that wasn't when this patient was speaking, right? There was no talking I'm assuming that you mean that interrupting the process of what she was experiencing.
Well, I was asking her to talk. I was
Uh,
asking her to tell me what she was feeling. I was asking her to say, okay, in essence, Wilson, I feel like I'm on an important spot, but is it to you, right? Just because it feels all gnarly to me doesn't mean it has meaning to you. And I'm speaking technical medical terms, gnarly, right? So in that first session, I wasn't forcing her to talk, but I was asking her questions and she was complying with my questions. It was that piece that she really initially disliked and wanted me to stop doing on the second session.
Yeah, just
And we,
the idea of interrupting. The idea of
yeah,
interrupting is something I've been kind of exploring because
yeah,
different cultures tend to interrupt more, interrupt less. You know, every family is a little bit different. And so it's just kind of interesting to me when she said you interrupted me,
yeah,
didn't interrupt her talking, right?
right.
You didn't actually stop her mid-sentence and
Oh,
ask
no,
a
no,
question.
no.
She was experiencing what she was experiencing from when you were like, receiving the treatment, experiencing something with mind, body, muscle, all,
Yeah,
sensory. And it's just interesting that she felt interrupted. That's just really interesting to me.
it is. She felt like I was interrupting her necessary process, her therapeutic process. And I respect that. I totally do.
Yeah.
I understand some people are nonstop with talking. Some people don't want to talk at all. Can we find a way then? I'm not going to continue with anybody, but especially a person like this, to continually ask questions. Once I can trust you of telling me if something's too much or wrong, once I can trust you to say, you know what, move over just a little bit, and oh, there it is right there. Once we form and trust is mutual, right? Then we can work in silence. I'm going to interrupt you once in a while to make sure we're still on track. But if that's really how you want to run this session, we'll do it. But remember, shared decision making to me is not about me complying with everything you want, nor the opposite. It's about an equal, fair power exchange at all times.
Yeah. Well, thanks for sharing all that. That was
Oh
great.
gosh, yeah, yeah. It's good to see you again.
Good to see you too. Thanks for your time. And how can people reach out to you if they'd like to learn more?
Yeah, the easiest way is through my website, which is waltfritz.com. Send me an email from the contact me button, or find me in my big mouth all over social media, posting videos and things like that. But feel free. I enjoy the dialogue. I enjoy skeptics. I enjoy people sharing not only their successes but also their struggles. I mean, that's what this world is all about. It's about providing a mentorship for that. So looking forward to come to Albuquerque in August. I hear that's a good time of the year. Nice weather in August in Albuquerque, right? Yeah.
Yes. Yes.
Nah. Well, last time I was in Albuquerque, there was a snowstorm.
Right.
So there you
Right.
go. Yeah, I doubt if
Right.
we'll have one. I doubt if we'll have one in August. So
Yeah. Well, we were in the midst of COVID coming on strong during that point. Boy, that was a different time, wasn't it?
it was. It was. Yeah. Yeah.
Yeah. Well, thank you so much. And I appreciate your time. Have a good one.
Thank you.
And there we have it. A special thanks to Walt Fritz for joining us today to talk about the techniques and what's new with manual therapy for speech pathologists to use as one of our approaches as we treat the patients we see each and every day. Please check out NiceSpeech Lady. That's a Facebook group. And also SLP Support and NiceSpeech Lady is a group on Facebook that is available to you. Please join the group and chime in. Also, please see us on all the social medias. And also, please just reach out. We have a contact us section on the website that you can send a secure message. So thank you so much for your time. Wanted to leave you with a thought for the day today from Og Mandino. Always do your best. What you plant now, you'll harvest later. Thanks again for your time and have a great one.